Okay, hi, good afternoon, everyone. We'll start the class. So today's lecture is on the optic nerve. We'll be covering this under anatomy, physiology, clinical examination, and localization. I'm hoping that you're all able to hear me. If there are any problems, just leave a comment in the chat section. So as I said, today we'll cover this under two sections. First is anatomy and physiology. So I think we're all pretty familiar with the basic anatomy of the optic nerve. Just a small revision. A very important factor to remember is that the optic nerve is actually not a nerve. It is a white matter fiber pathway running from the retina to the central nervous system. Um, Basically, it carries information from the retina to the visual cortex. Light hits the retina, travels through the optic nerve, the optic pathway in the visual cortex. The retina has rods and cones. Rods are greater in number. They're what is responsible for demonstrating low intensity light, as well as immediate night vision and peripheral vision, where the cones respond to color, and that is what is primarily responsible for your visual acuity. And the macula is made up entirely of cones, and so the macula is the point of central fixation, and it has the greatest visual acuity. It's also responsible for about the central 15 degrees of vision, so the most important aspect of the visual acuity is served by the macula. On fundoscopy, the macula appears as a small reddish area located temporal to the disc, where the optic disc, on the other hand, will appear as a 1.5 into 1.8 centimeter vertical ellipse, which is normally about pink to yellowish white, and it is responsible for the physiologic blind spot on visual field depth. Now, the optic nerve itself is formed by the axons of the retinal ganglion cells, and throughout the optic nerve, there is a spatial orientation that is maintained. So there are certain parts of the retina which are encoded spatially throughout the optic pathway all the way up to the visual cortex. Right? So 90% of the optic nerve fibers actually arise from the macula. So we can see how important the macula is. And hence, optic nerve dysfunction usually represents macular dysfunction. So that's why optic nerve dysfunction leads to problems with color vision, visual acuity, and leads to central scotoma. Now, the optic nerve itself is a 5 centimeter long tract. There's an intraocular part, which is 1 millimeters, an intraorbital part, which is about 25 millimeters. That's the longest part. There's an intracanalicula part, which is about 9 millimeters. There's an intracranial part, which is 12 to 16 millimeters. And that is the only variable part. The others have all fixed lengths. The intraorbital part, or the part which is behind the eyeball, that is 25 millimeters, and it is a little bit tortuous and sinuous. There's an extra 8 millimeters of redundant length, which helps when there's proptosis. So it allows for about 9 millimeters of proptosis before the nerve will begin to tether and cause problems. Now, after the optic nerves, the two optic nerves will join together and form the optic chiasm. The optic chiasm will lie about 10 millimeters above the pituitary gland. And the optic chiasm usually ends up lying a little bit behind the pituitary, despite whatever is shown in this image. So in 80% of cases, it does lie above the sella, but more posterior to the pituitary. In 10%, it actually might lie quite anteriorly, and the optic nerves could be quite short. And the optic tracts could be quite long. So that is called a prefixed chiasm. And in 10%, it might lie more posteriorly. So in that case, the intracranial optic nerves will be quite long, and then the optic tract will be a little bit more short. So this, whether a chiasm is prefixed or postfixed, is actually quite important when we're trying to figure out different visual field defects that can be caused by lesion present in that area. Another important thing in this region is that at the level of the chiasm, first of all, only your nasal retinal field fibers will cross. Temporal visual field fibers and nasal retinal field fibers. The inferior nasal retinal field fibers will actually cross, and then they will enter the opposite optic nerve before they go back and enter the optic tract. So this is known as something called, this is called as the von Willebrand's knee. Okay, and that also can be affected in any lesion which might be present in this region. For example, tuberculum selameningioma could particularly affect this junction where you have the optic nerve fibers of one side, and then you have the inferior nasal retinal field fibers of the opposite side. So that can lead to something called a junctional scotoma. Okay, so that's what we are seeing here. This, on the right side, the optic nerve is affected. That is why we have a central scotoma over here. And on the opposite side, the inferior nasal retinal fibers are affected, which means that the superior temporal quadrant visual field fibers will get affected. So that's what a junctional scotoma looks like, which happens when there is lesions which is located at the junction of the optic nerve and the chiasm. Like, for example, a tuberculum cerebelli. Right, so let's discuss the visual pathway itself. So when we're starting out, it starts with the optic disc and then goes into the optic nerve. At the level of the optic disc, the macular fibers are going to be located more towards the temporal side of the disc because the macula is on the temporal side of the disc. And then as the nerve starts going posteriorly, all the macular fibers move to the center of the optic nerve. The optic nerve itself is split vertically, so the nasal retina is represented medially and the temporal retina is represented laterally. So with the optic nerve, it's quite clear. The macular fibers, so this is the optic nerve. The macular fibers will be in the center. Okay, and it is split vertically. So on the nasal side, for example, you have the nasal retinal field or the temporal visual field. And on the temporal side, you have the temporal retinal field or the nasal visual field. Okay, so this is maintained throughout the optic nerve. Then, as we know, the nasal fibers of the retina will cross. The inferior nasal fibers will go into the opposite optic nerve, forming the what Willebrand's knee, and then go posteriorly, right? So the temporal field fibers will remain uncrossed, and they will go into the same side of the optic tract, right? The medial fibers or the only fibers will decussate in the chiasm, and the way that they decussate is also quite important. So the optic chiasm is tilted a bit. So the anterior part is located more inferiorly, that's here, and the posterior part is located more superiorly. In the center of the chiasm, the macular fibers are crossing, but anterior-inferiorly, that is where the inferior retinal fibers are crossing. Okay, and then superiorly, the superior retinal fibers are crossing. Remember, so these are retinal fibers. Okay, so these are, for example, in this region, you would get the nasal fibers of both sides, which are of the inferior retina. So this will correspond to the superior visual field of the temporal side on both sides. On the other hand, posteriorly and superiorly, this is where you would get the decussating fibers of the superior retina, but the nasal retina on both sides. So correspondingly, you will get the inferior temporal visual field on both sides. Right? After that, the optic chiasm will form the optic tract. The optic tract is a little bit more complicated. In the optic tract, initially we know there is first all the nasal fibers, since they have just crossed, they will be located medially, while the temporal fibers will continue on and go into the temporal or the lateral part of the optic tract. So in the optic tract, first you have the nasal fibers located medially over here, and then the lateral and the temporal fibers, that is the temporal retinal fibers, not the visual field fibers, located laterally. Okay, and the superior part of the retina will be located superiorly, and the inferior part of the retina will be located inferiorly. With distance, the optic tract will rotate medially on both sides. So what happens, your superior fibers of the retina end up lying medially, and the inferior fibers of the retina end up lying laterally. Okay, so this is a representation of the retina. So the superior fibers of the retina lying medially, and the inferior fibers of the retina lying laterally. Okay, and similarly, as we know, this is on the medial side. Initially, we have the nasal fibers. So the nasal fibers end up lying inferiorly. And on the lateral side, we have the temporal fibers, and the temporal fibers end up lying superiorly. Okay, so this entire optic tract will turn 90-degree clockwise, and this orientation will then be maintained till the lateral geniculate body is. Okay, so as we have discussed, the nasal fibers lie inferiorly, and the temporal fibers will lie superiorly. The superior retinal fibers will, because after turning, will lie medially, and inferior retinal fibers will lie laterally. Another thing is, the fibers which have crossed, they will enter layers 1, 4, and 6 of the lateral geniculate body, and the uncrossed fibers, so the temporal fibers, they will enter the layers 2, 3, and 5 of lateral geniculate body, following which the fibers from the lateral geniculate body will form parietal and temporal radiation. So we know how these go. This is the lateral geniculate nucleus. There will be an optic peduncle arising from here, and from that, the radiation is spread out and travels through the parietal lobe, around the atrium and the occipital horn, and then around the temporal horn to form the temporal radiation, which is going to go all the way up till the temporal tip, and turn back from the temporal tip only about 2.5 to 3 centimeter behind the tip. Follow the roof of the temporal horn and run back and go again to the visual cortex. So there's a direct pathway from the optic peduncle to the visual cortex for the parietal fibers, but the temporal fibers will take a bit of a detour, wrap around the superior roof of the temporal horn, form a Mayer's loop over here, and come back and enter the visual cortex. So remember, there are two important loops when it comes to the visual pathway. You have the von Willebrand's knee, which is also a loop where the inferior nasal retinal fibers enter the opposite optic nerve. And then you have the Mayer's loop over here, which is the temporal radiation, which is running over the roof of the temporal horn and the temporal lobe. Okay. So as we know, this is the superior radiations. So they will represent the superior retina. Okay. So for the retina, it is a superior retina. But for the visual field, it is going to be the inferior visual. Okay. So another way to remember is the upper part of the brain, that is the parietal lobe, represents the opposite visual field. So it represents the inferior visual field. And the lower part of the brain, that is the temporal lobe, represents the upper or the opposite visual field, that is the upper visual field. Okay, but they correspond to the same area on the other. Following which these fibers will reach the visual cortex, and here the upper retinal fields, again remember the upper retinal fields, not the upper visual field. The upper retinal field gets expressed on the upper side of the calcarein fissure. The lower retinal field gets expressed on the lower side of the calcarein fissure. So again, this upper side of the calcarein fissure has the upper retinal field. So again, its retina will be superior, but the visual field again will be the inferior part. Same for the lower lip of the calcarein fissure. It will have the lower part of the retinal fields, but the superior part of the visual field. The macula here will be represented directly at the occipital pole. Right, so that is about the anatomy and physiology of the optic pathway. So we'll come to a discussion of how do we evaluate the visual pathway and localize lesions in the visual pathway. So a lot of this is something we are quite familiar with. So we'll just have a very small overview of some of these things. So there are basically three things we have to evaluate: the visual acuity, color vision, and the visual fields. The fundus is a completely separate thing that we will not be discussing in this lecture. So the visual acuity, so this is usually evaluated through the Snellen's chart. It is documented as 6x6 to 6x60 in Europe and 20x20 to 20x200 in the US. So we follow the 6x6 to 6x60 denomination. Okay, so a lot of people do face some confusion as to what this number represents. Okay, and it is very easy to sometimes get confused with this number. Okay, so the first important thing to remember is that this number represents meters. It does not represent feet. Okay, so this is feet, 20x20, but 6x6 is in meters. Okay, so let's not get confused there. And what do the numerator and the denominator mean? For example, if somebody's visual acuity is 6/18, it's very straightforward to remember that this person with a visual acuity of 6/18 is reading something at 18 meters that a normal person, the other way around. So what a person is normal person with normal visual acuity is able to read at 18 meters, the patient is able to read only at 6 meters. So the patient is standing at 6 meters. Okay, and the person with a normal visual acuity is standing at 18 meters, and they're able to read the same thing. Okay, so it's just a very straightforward way to remember it, that the numerator is always going to remain 6, and the denominator is always going to change. Okay, so remember that the patient is reading at 6, whatever a normal person with normal visual acuity is reading at the second of the denominator number. Okay, so similarly, a 6x60 visual acuity means that whatever a patient is reading at 6 meters, the person with normal visual acuity is able to read at 60 meters. Okay, so that's quite bad. On the other hand, 6/5 is quite nice. So whatever the patient is reading at 6, a normal person is able to read at 5. Okay, so 6/5 is the opposite of whatever is we have after 6/6. Like 6/6 and beyond is normal and just further worsening visual acuity. 6/5 on the other hand is quite good visual acuity. It represents that you have better visual acuity than most people would. 3/60 on the other hand can also be something we can come across once in a while. So here what is happening is that the person is not able to read anything even at 6 meters. So they're not able to read the first line also. So then they can walk up closer, they can go 5, they can go 4, they can go 3 meters and see when they're able to read the first line. So the distance at which they're able to read the first line would become the numerator over here. So a 3 by 60 person, whatever a normal person's reading is 60, the reading is 3 meters on the other hand. Okay. Similarly, you can also have a 3 by 18, but that doesn't really make any sense, because if you're able to read the line corresponding to 18 meters, you should have been able to read the previous lines as well. So you probably have a better visual acuity than 3 by 18. Okay, so the second thing is that you can check color vision, which is done with the Ishihara charts. Important thing to remember about color vision is that if color vision is affected, either your macula is affected, the optic disc is affected, or the optic nerve is affected. Any lesions beyond the geniculate body are not really going to affect color vision. Right, so coming now to the visual field testing, a little bit of the more complicated area when it comes to the visual pathway testing. So how this is done is, now it is just automated, but if you have to check it bedside, it can be done by confrontation testing. And this is where a lot of people can go wrong. So it's a very straightforward system if you follow. So basically, what we have to do is sit at the level of the patient. Both the patient and the tester would have to sit at the same level, facing each other. Okay. And one of the best ways to do it is that you close the eye which is not being tested with your own arm. So the examiner should go ahead and close the eye which is not being tested with his own arm. This does two things. It first of all makes sure that the eye is closed. And the second thing it does is that it enables you to maintain a fixed distance from the patient. So this distance will always be maintained. So you're not moving front and back, you're changing your visual field. Okay. So if usually we tested with red and white hat pins, routinely a 10 millimeter white hat pin is used. If you want to test the pregeniculate pathway, you can use the red pin as well. So that would work better. If the visual acuity is low, instead of using the hat pins, you can even test it with finger counting and hand movements as well. Right, so you sit opposite the patient, make sure that the patient's eye is shut with your own hand, and keep this arm length distance from the patient. Okay, then you have to make sure that the patient is constantly looking at your eye, and you should also be constantly looking at the patient's eye only. Because that eye contact has to be maintained throughout the entire testing of the patient's visual field. Following which, what you need to do is divide the visual field into 4 different quadrants. Okay. And bring this hat pin, okay, from the edge of the quadrant towards the center in all 4 quadrants. Okay. And bring it to the exact middle of the distance between both your eyes. Okay, so that way you'll be able to compare the blind spot of the examiner as well as the patient, and make sure that you're testing out properly. So whatever you're able to see and the patient is not able to see should correspond. And if they're not able to see an object in any particular area, that means that the visual field is affected in that area. Right, so that's how we test the visual field using confrontation testing. So let's look at how different lesions in the visual pathway will affect the visual fields. So any lesion involving the retina will cause particular visual field effects. Now these lesions could involve the papillomacular bundle, which is running between the macula and the disc. And that is the most important bundle which is responsible for the visual acuity itself. So toxins will particularly affect this papillomacular bundle. So whenever that is affected, you have something called a secocentral scotoma. So that is what affects the entire the field which is arising from the macula. So this is what is known as a secocentral scotoma. You have a physiological blind spot here, and then you have the secocentral scotoma representing the area of the macula. Okay. Then you could also have vascular lesions like retinal artery branch occlusions which could arise. So a way to identify it would be that the retinal artery branch occlusions would not cross the horizontal meridian. So as we can see over here, they're not going to cross the horizontal meridian and go on to the other side. You could also have lesions arising from the optic disc itself. So a lesion at the level of the optic disc itself could also cause particular visual field effects. Usually what it causes is an arcuate scotoma. Okay. So, for example, if glaucoma exists and it damages the nerve fibers at the edge of the optic disc, it is going to produce these arcuate blind spots. So these will basically be scotomas arising from the blind spot and extending to the region of the macula. Because again, it is affecting the papillomacular bundle as well. Okay. So initially it will form basically an arc, and that is what's known as cedal scotoma, which time the entire arc will become a complete ring like this. That is what is known as a germ scotoma. Okay, so you can have other visual field effects apart from what we discussed with arcuate scotomas, which arise because in the presence of papilledema. One is papilledema itself can enlarge the blind spot. Okay, so you could have a large physiological blind spot which is present in patients with papilledema. Other things which can happen is that sometimes because of papilledema, you could have an exudate spreading into the macula, and that also could further create blind spots or visual field defects. Apart from that, you could also have complete transient visual obscuration because of a sudden increase in the ICP. You could have chronic papilledema, which is leading to optic atrophy and further increasing the physiologic blind spot. Sometimes you can also have papilledema in patients who have hydrocephalus. And when they have hydrocephalus, the third ventricle could become quite large. It could be pressing on the chiasm, leading to splaying of the chiasm, which causes compression of the chiasm on both sides against the ICA, leading to a bilateral lateral chiasmal syndrome, and we'll discuss more about this as we go on. Sometimes because of raised ICP, you can also have cerebral herniation, which can occlude the PCA, in which case the patient could also develop a macula-sparing hemianopia. Okay, so because this is going to affect the visual cortex, you're developing a hemianopia, but because the occipital pole is also supplied by MCA branches, that's why the macula is usually spared, and you will develop a macular-sparing hemianopia instead. Right. So coming to further ahead in the localization scheme, you could also have lesions which affect only the optic nerve. This could be, for example, a retrobulbar neuritis. As we have discussed, the optic nerve, if it's affected, has 2 or 3 very specific features. First of all, because 90% of the fibers are macular fibers, and the macular fibers are quite sensitive within the optic nerves, it significantly affects central vision and affects visual acuity as well. Also, it affects color vision. So optic nerve lesions particularly are known to affect color vision and visual acuity. If it's retrobulbar neuritis, you will also get a painful eye and a central scotoma. Apart from that, you could also have a painless lesion affecting the optic nerve. You could have optic nerve compression, for example, from a meningioma or a schwannoma. Again, it is also going to lead to this effect of the visual acuity and color vision being affected and the development of central scotoma. Whenever the optic nerve is affected, always make sure that you check that the opposite visual field does not have a defect. Okay, so always check for a defect in the opposite superior temporal field, because there might be a junctional scotoma, which would indicate the lesion is present at the level of the junction of the optic nerve and the chiasm, which will help you to localize what the lesion could be. We can also have lesions which affect the optic chiasm. So the optic chiasm has multiple different syndromes. Okay, so we've already discussed a few things about the optic chiasm. Now, as we know, the optic chiasm lies usually behind the pituitary gland, as we can see over here, and closer to the dorsum sella. But if it lies on the dorsum sella, it is a post-fixed chiasm. It lies on the tuberculum sella, it's a pre-fixed chiasm. Okay, most commonly lies just behind the pituitary near the dorsum sella. Okay, now, unlike what is happening with the optic nerve, the papillomacular bundle is quite safe within the chiasm. It is less vulnerable in the chiasm than it is in the optic nerve. That is why whenever the chiasm is affected, you usually do not get visual acuity defects. Patients don't usually complain that they're not able to see. And that's why a lot of them don't even pick up on these visual field effects, because they're able to see clearly. It's that the visual field is being slowly affected. Only very late in the course of the disease do the macular fibers get affected. And so that is why there's a very late onset of visual acuity defects in patients with pituitary adenomas and craniopharyngiomas, while they've probably had temporal field defects for quite a long. So as we already know, the retinal fibers, the inferior retinal fibers will cross anteriorly and the superior retinal fibers will cross posteriorly. So again, the superior visual field fibers are crossing anteriorly and the inferior temporal visual field fibers are crossing superiorly. And that's important for us. So as we've already discussed, the anterior chiasmal lesions affecting the anterior part of the chiasm, that is the junction of the optic nerve and the chiasm. So you will get optic nerve compression on one side So you'll get a central scotoma. And because the inferior retinal fibers will cross and form the von Willebrand's knee here, you will get a superior temporal field defect on the opposite side. So that is your anterior chiasmal lesion. Usually something like a tuberculum salameningioma might cause this. A standard chiasmal lesion, on the other hand, causes compression on the chiasm and affects the crossing nasal fibers, so will lead to a bitemporal hemianopia. As we know, because the macular fibers are quite safe in there, it usually does not affect vision till late. Now, optic chiasm lesions could be affected from lesions which are either pressing the chiasm from below or pressing the chiasm from above. Okay, so a pituitary adenoma is growing below the optic chiasm. It's arising out of the pituitary. So that's a lesion which is usually coming from below. A chordoma could also come from below. A lesion which is coming from above would be a lesion maybe arising near the infundibulum or the median eminence of the hypothalamus, for example, like a craniopharyngioma. So if there is a lesion which is coming from below, as we know that the optic chiasm is tilted and almost arranged horizontally, we know these are the inferior retinal fibers, these are superior retinal fibers. Okay. And these are the inferior retinal fibers with the superior visual field fibers. So any lesion which comes from below, like a pituitary adenoma, is going to first affect these inferior retinal fibers, but the superior temporal fibers. So a pituitary adenoma, okay, will be affecting the temporal fields, but the superior temporal fields first. Okay. On the other hand, if there's a lesion coming from above, that is a craniopharyngioma, for example, it is going to first affect the superior retinal fibers. Okay. So the superior retinal fibers, as we know, represent the inferior visual field. So first, what would be affected in a craniopharyngioma would be the inferior retinal fields, again the temporal ones, so out here. Now, between both of these, the superior temporal fields are not very important for vision, but the inferior temporal fields are quite important. We require this to go down the stairs, for example. So it is it is quite common that people who have a craniopharyngioma, for example, will be more likely to notice the visual field effects than patients who have a pituitary adenoma. This will be noticed a little bit more late, when the inferior fields are also being affected, while the craniopharyngiomas and the visual field effects might be noticed a little bit more early. Okay, so as we have already discussed, chiasmal compression from up. Chiasmal compression can very rarely happen from the lateral side also. That is what is a lateral chiasmal. So this is quite rare. Okay, and it can happen with, for example, a cavernous IC aneurysm, as we can see over here, which is causing compression of the lateral part of the chiasm. As we know, the lateral part of the chiasm contains only uncrossed temporal fibers. Okay, so this usually only causes a nasal field effect. Quite rare, quite most likely unnoticed. Sometimes this cavernous IC aneurysm might also push the chiasm towards the opposite IC also. So you have ipsilateral compression and you also have contralateral compression. And you can develop something known as a binasal hemianopia, which is very, very rare. Okay, and that is what is a bilateral lateral chiasmal syndrome. This can sometimes even happen with the hydrocephalus when there's the third ventricle is pushing down onto the chiasm and then it is getting splayed against both the IC. So that can also cause a bilateral lateral chiasmal syndrome. Okay. Now coming to our optic tract lesions. Now optic tract lesions are a little bit more complicated than optic nerve and optic chiasm lesions. So what we have discussed so far in optic nerve and the optic chiasm, there's very clear-cut, well-defined visual field effects. You have scleroscotoma, you have temporal, you have bitemporal hemianopias, you have nasal hemianopias, and clear-cut field effects. In the optic tract, on the other hand, as we know that the optic tract is going to undergo a 90-degree medial rotation, which happens slowly throughout the length of the optic tract, because of which any lesion which is pressing from one side is not going to particularly affect one area of the retinal field. Okay, so the retinal field fibers might have only turned, for example, by about 45 degrees at the level of the compression. So you might affect 45 degree of these fibers and 45 degree of the other side fibers. So you get very incongruous defects when you have lesions in the optic nerve. So it's a very striking feature of optic nerve defects. If you're finding any incongruous homonymous hemianopias, okay, so for example, you have this is the visual fields. Now, if you had a lesion involving the entire optic tract, you would see a clear-cut, congruous, homonymous hemianopia. Okay, but for example, the optic tract is turning and it is not straight as it should be. You might not see a congruous homonymous hemianopia now. You might see that some fibers are affected more, so you might get a larger visual field defect here, and you might get a smaller visual field defect on one side. So that's an incongruous homonymous hemianopia, and that is most likely with optic tract lesions. Okay, it is also possible to get incongruous visual field defects with your parietal and temporal lobe regions. We'll discuss that in more detail. But if it's a homonymous hemianopia, it is involving in the entire half of the field and it's incongruous, we should localize to the optic tract. You can also have lesions of the lateral genicular body. These also can cause an incongruous homonymous hemianopia, but these are very, very rare and very unlikely. So lesions can be present in front of the genicular body or behind the genicular body. Both of them will end up causing a homonymous hemianopia. But how do we differentiate? Remember that the neuron of the retinal ganglion cell, it is going to go and synapse onto the lateral genicular body neurons as well. So that is now the second order neuron which is arising from the genicular body. Okay, so a lot of things will happen which will make sure that you're able to differentiate between a pregeniculate and a postgeniculate lesion. So in a pregeniculate lesion, as we've seen, you will see a variable defect with sloping sides because we know that the optic tract is turning. On the other hand, in the postgeniculate lesions, you should get an absolute defect with steep sides because there's no turning happening of the radiation from after the lateral genicular body. Also, the fibers which supply the pupillary reaction, which go to the pretectal nucleus and the Edinger-West arm nucleus, have left the lateral genicular body before the visual pathway reaches that region, which is why a lesion which is causing a pregeniculate pathway being affected will also cause a problem with the pupillary reaction, but a postgeniculate lesion will not. Color vision will be affected with the pregeniculate lesions, but not with postgeniculate lesions, and the optic disc will be atrophied with pregeniculate lesions because it is a direct continuation up to the lateral genicular body, but because this is a second order neuron, the optic disc will be normal in postgeniculate lesions. So there's a lot of different postgenicular lesions which can arise. So this we can see over here is a lateral genicular body. We know from the lateral genicular body you get the parietal radiations and you get the temporal radiations, which will form a Meyer's loop and come back here. Right? So the parietal radiations represent the superior retina. The temporal radiations represent the inferior retina. So this is the visual field is crossed. The parietal radiations represent the inferior visual field and the temporal radiations represent the superior visual field. So it's quite straightforward. If you have a homonymous defect in the superior visual field, okay, it is a temporal lesion. If it is a homonymous defect in the inferior visual field, it's a parietal lobe lesion. Okay. Sometimes if you have a large enough lesion which is affecting the parietal lobe and the temporal lobe, then you can get a full homonymous hemianopia. Okay. Now, at the level of the calcarein cortex, we know that the superior cortex corresponds to the superior retina or the inferior field. The inferior cortex corresponds to the inferior retina or the superior field. The occipital pole corresponds to the macula. So usually when you have a visual cortex lesion, for example, a PCA infarct, you're going to get a macular sparing hemianopia because the macula is also supplied by the NCA branch. This is a macular sparing hemianopia. Sometimes you might have a lesion just at the occipital pole, for example, from trauma. So in that case, you could get a lesion only involving half of the macular cortex. So that is a very unlikely lesion. Sometimes you might get a lesion in the intermediate part of the visual cortex. So the fibers which are anterior and the fibers which are posterior are all spared. So the macula is spared, you have intermediate visual cortex loss, and then the periphery is again spared. So these sort of visual field defects could arise from lesions of the occipital pole. Right. So another important thing to remember is that sometimes if you're testing and you find a homonymous hemianopia, you have to make sure that it is actually a true homonymous hemianopia and not an attention deficit. Okay, so these attention defects or attention field defects can arise from lesions involving the parietal lobe. So because the parietal lobe is also responsible for spatial orientation and spatial attention, parietal lobe lesions can cause a pseudo-homonymous hemianopia. So you can just ignore all the stimuli from one side of the visual field. To make sure that this is not happening, there's a way to test this. Basically, the patient and the examiner sit in front of each other. Both of them keep both their eyes open, and then you stick out both your hands in front of the patient off to the sides. Okay, and then you move the fingers of one hand and ask the patient if he's able to see, or he or she is able to see that the fingers are moving. So you do that on one side and then you do it on the other side. And this makes sure that the patient is able to see on both sides. If they're clearly not able to see on one side, it means that there's a true homonymous hemianopia. And then you proceed. Then you know the fingers of both sides and ask them to see if they're able to see the fingers moving on both sides. If they're able to clearly tell you that they're able to see it moving on only one side, it means that they're ignoring the other side and they have an attention hemianopia. So that usually corresponds to a defect in the posterior parietal lobe. Right. So that is all for today's lecture. So we can discuss a few questions. If possible, can you localize this visual field defect? Is it arising from a lesion in the left optic tract, from the right parietal lobe, from the left parietal lobe, or from the right temporal lobe? You can leave the answers on the chat box. Okay, so let's see. These are our visual fields. Always remember that whenever there's a field defect and these are being demonstrated, it's always a visual field and never the retinal field. Okay, so this is our right eye, this is our left eye, this is superior, and this is inferior. So what is affected? First of all, we should always go through 3 or 4 basic steps to identify what is the defect exactly. Okay, so we have the same side being affected in both the eyes. So the problem is on the left side. And the problem is in the superior field. So you have a left superior homonymous because it is affecting the same side field defect. Okay. If it's a homonymous field effect, it is going to obviously arise after your optic chiasm. Okay. Because now everything is crossed, so only after the optic chiasm. So you can only have the optic tract, the optic radiation, and the visual fibers of the visual cortex being affected. Okay. So since the left side, the problem has to lie on the opposite side. So it has to lie on the right side. We know it's on the right side and it is after the optic chiasm. Okay. Now it is affecting predominantly the superior field. Okay. And it is a bit incongruous. Some part of the field is being affected more on the right side than on the left side. Okay. So this is most likely to be arising from a right temporal lobe defect. Okay. So as I had mentioned, lobar defects are also going to be slightly incongruous. Okay. So, but this is not an optic tract lesion because an optic tract lesion would have involved a significantly larger component of the visual field on one side and maybe a smaller component of the visual field on the other side, but it should be a little bit more of both the superior and the inferior visual fields. The temporal and parietal defects also will be slightly incongruous as well. So this fits more into a right temporal lobe defect and an optic tract defect. Right. The second question is the lesion in which area can cause this particular defect. Is it arising from the retina, from the optic nerve, from the optic tract, or from the visual cortex? So this is a defect arising from the visual cortex, which has affected both sides. This is the macula sparing bilateral involvement of the intermediate visual cortex. Because the periphery is spared, the macula is spared, but the intermediate part is involved. Okay, so that can only happen at the level of the visual cortex and nowhere else. And that is all for today's lecture. Thank you so much for attending. If you have any questions, you can leave them in the chat box or in the feedback form provided afterwards.